everybody hear me?
We can.
Okay.
Yeah.
I'm Andrew Colin. I'm the Director of Pediatric Pulmonology in Miami. For those of you who have not met me, I took the liberty, with permission of Dr. Koumbrolis, to invite two outsiders to this meeting. One is already online. This is Dr. Indhu Khosla, who is in Mumbai, and we have known each other for now the better part of 20 years. She is a pediatrician with interest in pediatric pulmonology, and we have exchanged a lot of information, pieces of information, papers, etc. And she contributed one of the cases that I will present today. And the other person who is still not in line, and I hope he joins, is Professor Ashatel, who is in Beersheba, Israel, and has been a renowned researcher. You may be familiar with the TAL score from bronchiolitis that is named after him. And he also contributed a case. So if there are comments, they could actually give us more information. The talk that I'm giving now was triggered by a discussion last week about CVID and immune deficiencies, and I'll show you the apropos. And I just thought that this might be an opportunity to discuss the topic more broadly. And this is about obliterative bronchitis in children. And you see in parentheses membranous, and I will again introduce the context of membranous in a minute. So the concept of bronchitis obliterans, and be not confused with bronchiolitis obliterans, is not entirely new, but it's rarely discussed. If you do a search, you will stumble into bronchiolitis obliterans all the time, and it is very difficult to find the few cases that actually deal with bronchitis. As you may remember, the difference between bronchi and bronchioli is that bronchi typically involve the first 5 to 6 generation, and bronchioli is everything beyond that. So basically, we are talking about obliteration of proximal airways, and the emphasis in this discussion will be the visibility by bronchoscope. So the idea that these things exist, including in pediatrics, is not entirely new. This is a paper from 1997 by Jules Allen and colleagues that talks about a child post-Mycoplasma pneumonia that shows obliteration, and I will show you just a few examples on the sample. These are bronchi that are obliterated. This is a section of the lung with areas of obliteration. Here is a higher magnification, what used to be a bronchus, and that is, again, this is fibrinous tissue and collagen and cartilage, making this lung completely dysfunctional. When one looks at the literature about possible etiologies, they are not at all clear, but Mycoplasma is a theme. Other infections may be there, but not elaborated on. Pneumoconiosis in minors has also been observed. So in 2006, we published this paper that is termed membranous obliterative bronchitis. And again, I'll elaborate a bit on the concept of membranous later, which was written by myself, Dave Waltz, who is a colleague at the division, Fanis Chilianis, who was a visiting colleague that was with us for 6 months from Athens, and Dr. Nozay, who was the pathologist. And this is a series of 3 cases of cystic fibrosis with unusual bronchoscopic findings. They were all in their 20s, so they are not strictly pediatric cases. So here is case number 1. She was in her early 20s with relatively advanced cystic fibrosis, clinically not so much radiologically. She came with a fever, severe cough and discomfort, and the CT scan eventually led to these findings here. You see that there is some collapse or inflammation with potential cavitation, And when she didn't do better, we actually did the bronchoscopy. And what we found in the bronchus that was supposed to be feeding this part of the lung is that we saw this pit with obliteration, where clearly the bronchus north of this was patent. We don't see it well here, but this bronchus was obliterated, a finding that we did not expect at all. We had no experience whatsoever with this condition. We tried to breach it with a blunt instrument. What you can see here is actually a balloon catheter that we tried to breach the membrane with, and then the hope was that if we are able to breach it, and again, this was an assumption that it was a membrane because it was rather transparent looking, although we were not sure entirely that this indeed was a membrane. When it didn't break, we left it alone. And the lady eventually improved with antibiotics alone, and we did not need to go back. Case number 2 was again a very similar presentation, different patient, similar age. And what we saw here was the obliteration. You see a patent bronchus here, an obliterated bronchus here that looked very membranous. What you can see here, it was really transparent at the point. And then we tried to breach it with this instrument. We were actually successful. It broke. There was not really very much secretions. She improved, and we never went back and eventually did well. The most striking case that we had was Marty, who was in his 20s and was after lung transplantation. And what we saw in his case, of course, we went back for many bronchoscopies because these cases actually have repeated bronchoscopies for transbronchial biopsies to assess for rejection. So we had opportunities to go back many times, and what we were progressively seeing was that we started to see narrowing and partial obliteration in membranes with repeated bronchoscopy, particularly in the left upper lobe and the left lower lobe. You can see a patent bronchus here, a bronchus that is partially obliterated here, and a bronchus that is quite obliterated here. We were able to take a biopsy from one of the bronchi that I will show in a minute. I actually should have proceeded the next with this one. We did a biopsy with a tool and put it under the microscope. This was then read by the pathologist. And what it was, it shows granulation tissue, loose connective tissue. There was actually a membranous a surface to it, but in fibroblastic inflammation. But then as you went to what then we perceived to be sort of the center of the forming membrane, it became acellular, and it seems to be a transition to a fibrinous acellular and avascular tissue, which we thought probably represent the membranous transparent part of it, which probably was not an active metabolic tissue, but we were not sure. So Marty then presented one day with marked worsening and with a collapsed lobe. And when David, my colleague, bronchoscoped him, he realized that that where there should have been a bronchus, it has actually vanished. So what he saw here is 2 patent bronchi and a mucosa that covered the site where there should have been a bronchus. And what we used to see by then was that there is a pit there when the bronchus becomes obliterated, but maybe when the pit recovers or resolves, it actually becomes completely obliterated and covered by normal mucosa. With the knowledge that there was a bronchus there, David went on and took the young man to radiology. And I still don't understand how they did this feat, but they went transthoracically with a catheter, and then they defined by contrast the bronchus. They were able to go in, inject the bronchus with dye, and what you can see here is the point of obliteration. So this point here would be this point here that is obliterated. What they then did, they put they put a needle in, and that needle pointed out where the orifice of the bronchus used to be. Then they did balloon catheterization, which is shown here, dilated the orifice that was narrowed by now discovered with the needle. And then what they did, they dilated it and they put a stent. This is the bronchoscope, pulling the needle, placing a stent, and that stent lasted all his life. He eventually died with lung rejection, but not because of the complications. And this bronchus then remained patent, and the atelectasis that I showed you has resolved. He offered us, however, the opportunity to speculate about what the process is in these cases. Now you see here 4 stages of obliteration of the bronchus. This is not necessarily representing, in fact, it does not represent one single bronchus, but we speculated that we start with this semilunar web. Here is a patent bronchus, here is a bronchus that starts to be obliterated. And what you see, this web forming here, it becomes larger, and we thought that there may be like a fan type of opening here. So this becomes narrower and narrower as the obliteration progresses. Then when it becomes really progressive, you remain with this little umbilicus here, which then persists to become a complete obliteration. And we thought that this progress is sort of centripetally as a fan or scythe-like motion along the circumference of the bronchial lumen. So we presented this case or this series of cases at ATS, then as a case presentation at ERS. We also presented him in our combined adult and pediatric rounds in Boston, and we sought help from people whether they were able to explain what is going on, and nobody could understand what this was. We then published it, and lo and behold, shortly after that, there was a letter to the editor for the now famous Anne Chang and Mark Everard, who complained that they actually have described this before us. And what they have described is a paper that talks about bronchoscopy findings in children with non-CF chronic suppurative lung diseases, and they speculated there is a progression, and as the progression occurs, there is what they called an obliterative-like lesion, which they called airway type 3, seen in segmental bronchus here. And the main message in their letter to the editor was not only to complain about what we were claiming to be a novel finding, but also they were opposed to the idea that this needs to be breached. And I will show you eventually the response to what they wrote. We agreed that it doesn't require breaching in every case, but those cases that appear to maybe be membranous could be breached. This here is a bit fuzzy, but it doesn't look membranous to me, so I'm not sure that there was a justification to try to interfere with it at this point. So what we ended up speculating is a number of things in this paper, and one was that membranes are more frequent than appreciated, but too distal for the reach of the bronchoscope. As bronchoscopes became thinner, we're able to go deeper and maybe see more cases of obliteration. And we shared this information with many colleagues. And then years later, we collected a number of cases which have been then published in Pediatric Pulmonology by my colleague Annabel Kizon, who used to be with us. And the other colleagues on the paper were Predrag Minic, who is in Serbia, Petr Pohunek, who is in the Czech Republic, Asher Tal, who hopefully is on this call in Beersheba, Israel, and myself. And the first case was one that Peter actually presented at ERS separately from this. This was a 17-year-old male with history of right-sided pneumonia, who had at age 3 and 4 months and remained asymptomatic subsequently. He came to attention because of right-sided chest pain, reduced breath sound of the right, that was many years later at age 17, and a chest CT with hyperlucent right lower lobe. Bronchoscopy revealed no proximal findings, but with the ultra-thin bronchoscope, obstruction of a number of distal lower lobe bronchi was noted, estimated at the 11th generation of the bronchial tree. So this is a bit of an outlier in the sense that this was really not large bronchi. This was a further generation, so this actually would qualify as bronchiolitis obliterans. I don't think that there are many papers about bronchoscopic view of bronchiolitis obliterans. Here is a series of views, the bronchoscopic views, and what you can see here, open bronchi, and as you go deeper, you see obliteration, 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 obliteration. Here is the video that he generously gave me, and what you can see here is as they go deeper, they see obliteration of a number of bronchi. This is a slightly longish video, and the purpose is not only to show you the obliteration. This is not the bronchus that is obliterated. So as he is pulling out, you see how distal it is. He goes back, he pulls, and you see more and more bronchi. So these are many generations out, and Peter estimated that this is 11 generations. I've never seen anything so distal showing pathology in bronchoscopy. Anyway, subsequently, a cyst was surgically removed that was characterized as a bronchial cyst. The patient did well post-surgery, but the hyperlucency persisted. It is our assumption that these bronchi were either obstructed, causing the disturbed aeration of the lung segment, or that the distal obstruction represents the interface between the bronchial lumen and the wall of the cyst that was subsequently removed. So I would like to emphasize this point, because I may be going back to it, is that what you may call a membrane or an obliteration may actually not be just the obliterated lumen, but actually represent the outside wall of a cyst or another formation that, if it would be pierced, could actually represent the inside of whatever that process is. In this case, could have been the bronchogenic cyst, but it may actually, as I will allude you later, maybe represent an abscess or a necrotizing pneumonia. So here is a case that we saw here at the Miller School of Medicine in Miami. This was a 3-year-old with pneumonia, presented in September 2005 with fever, diagnosed with pneumonia, previously history of mild asthma and chronic Montelukast therapy. Treatment was antibiotics, and no resolution of the infiltrates or the chest radiograph. When he came to us for a second opinion, what we saw was an atelectasis that apparently did not resolve, so the X-ray continued to show it, and here is the CT scan. So he was seen for consultation in our pulmonary clinic, minimal intermittent cough and no fevers, active with normal quality of life. Asthma was well controlled on Montelukast, the chest radiograph were unchanged, and we planned the bronchoscopy. And what the bronchoscopy revealed is that you see this patent bronchus and this pit that we assumed was, again, a type of obliterating bronchitis. Here is another view of the same. You can see the pit. One could claim this would have been a bronchus that never really formed, but it was in the location that one would have associated with the distal radiographic abnormality. So the decision during the procedure was not to attempt to breach the membrane. BAL and cultures were all negative, remained clinically unchanged 1 year after the pneumonia. And the question still remains, what should we have done? He was lost to follow-up. I can't tell you what the radiographic resolution was. Here is a much more dramatic case. This was provided by Dr. Ashatel, who I hope is on the call. This is a 3-year-old with progressive lung disease. So she was seen 3 weeks prior to the important admission that I'll describe to you soon with influenza A, and developed a Staph aureus bacteremia. She was readmitted because of respiratory distress, nasal flaring, intercostal retraction, and aphonia. She, in auscultation, has had high-pitched expiratory wheezes with a prolonged expiration, and remaining exam was unremarkable. So this was February 2, when she had her original pneumonia, maybe hyperinflation. She had a bacteremia that was treated at the time, and she had an influenza infection at the time. Clearly very hyperinflated. Unfortunately, the quality of the film is less than perfect. When she came a month later, when she came a month later, she was much sicker. She had a flexible bronchoscopy with prolonged inflammatory process involving the larynx, bifurcation of the trachea and main bronchi. A purulent plug was removed from the trachea, and she grew untypable Haemophilus influenza and Staph aureus. The BAL in the right mid-lobe revealed Staph aureus. She became really sick, and then they got this X-ray that showed a complete collapse of the left lung. And then the idea came that maybe they need to do a bronchoscopy, but also a bronchography. This was a technique that was largely abandoned in the 2000s, but actually was very revealing in this case. And what you can see here is that the bronchi are filled, but what you see is that they don't show this proliferation into smaller bronchi. These are bronchi that appear to be obliterated. And this is the bronchial tree. We showed essentially obliteration or plugging or some type of inability for the dye to spread as it should and affecting the both lungs. And so the idea came up that this is a bronchiolitis obliterans. And in fact, what you see in the bronchoscopic procedure that was following this was that you see bronchi, proximal bronchi that are completely obliterated, partially obliterated, completely obliterated in other regions. They tried to breach with a sharp instrument with little success. You can see a bronchus that is partially obliterated here, completely obliterated here, completely obliterated here, partial obliteration here. This progress was continuing. They gave her antibiotics. They tried to support her, but eventually she died. So with this bilateral process of obliterative bronchitis, this was post-infection, unclear which was the driver, but led to the demise of this child. Here is why pediatricians should know this. And this is an interesting case that was contributed by Dr. Khosla, who is on this call. 10-year-old with pneumonia. He presented with a 10-day history of cough and dyspnea without fever, no personal or family history of allergy, atopy, or chronic lung disease, past history of receiving 2 drugs for early tuberculosis, and that was 6 years prior to the current involvement. He was well nourished with no respiratory distress, cyanosis, or clubbing. Air entry reduced on the left side of the chest with bronchial breathing posteriorly, and other systems were unremarkable. He had no neutrophilic leukocytosis. Sputum and blood cultures were negative. BAL fluid and brush biopsy were negative for bacterial, mycobacterial, and fungal cultures. Molecular diagnosis for mycobacteria was also negative. Cytology showed 16% of eosinophils. An attempt to recanalize the airways that I'll show you in a minute by the brush biopsy catheter failed. His Mycoplasma titer, IgM, was positive. Investigations for autoimmune disease were negative. The patient was heterozygous for delta F508 mutation of cystic fibrosis. Gene sequencing was awaited at the time that I had this slide. I suspect that it eventually ended up being negative. So here is the X-ray. What you can see here is a complete collapse of the right lung. Here is a CT scan that was associated with it. You see zero aeration, complete obliteration of the bronchi on the left, significant abnormalities on the right, but nothing that would suggest bronchial serous involvement. Here is the bronchoscopy, and that was quite dramatic because it shows on the left side, here is a complete obliteration, probably complete obliteration, maybe partial obliteration on the bronchoscopy. And here is the three-dimensional CT scan that shows a relatively normal right lung and completely obliterated left bronchial tree with only the maybe 2 to 3 generations visible. Let me see if I can show you this video. Can you see this? This is a video of this three-dimensional study. And what you can see, the right lung normal, and the left lung, there is no shadow of lung at all. The good news about this kid is that he recovered, and the diagnosis was a post-mycoplasma complete obliteration of the bronchi of the left lung. He recovered. He is now probably 13, 14 years old. Maybe Indhu would comment on that later. Seems to be doing okay. As you remember, the first slide that I showed you by Jules Allen pointed to the possibility of mycoplasma causing this severe obliterative bronchitis. A search of the literature also showed a number of similar cases with severe lung damage reported in the Chinese literature, but I could not read the Chinese papers, and the abstract was available only in English, so I cannot give you the details. Incidentally, there is quite a bit of literature from the Far East, including Taiwan and China, about severe presentations of mycoplasma, including not only these obliterative cases, but also necrotizing pneumonia, a series of five cases from Taiwan, as well as numerous cases from mainland China. How about other reports in the adult world? Very difficult to find them, again, because most of the literature searches will lead you to bronchiolitis obliterans, which I think is a much more common disease that we see in multiple situations, less as post-infectious bronchiolitis obliterans, that is the pediatric presentation, and more of the immune suppression related cancer, transplant related obliterative bronchiolitis that we see more commonly, and is probably a completely different entity. But here is an example of a paper that from the United States, fatal progressive membranous obliterative bronchitis, a sequela of influenza is the question mark. And by the way, it's interesting, sequela is the singular and not a plural in this Latin word. So I was wondering, because A typically is plural in Latin, but in this case, AE sequelae would be the plural, just for your education. 34-year-old woman, history of uncontrolled type 1 diabetes mellitus, developed bronchiectasis and chronic hypercapnic respiratory failure after an episode of severe multilobar pneumonia and ARDS. No history of pulmonary disease or respiratory infections until these events. Respiratory culture at the time grew MSSA, and PCR was positive for H1N1 influenza. Prolonged mechanical ventilation and was hospitalized for 6 weeks. Subsequently, she had multiple admissions for progressive lung disease, with bronchoscopies revealing progressive obliteration of bronchi, tear-held demise, similar to the cases of Marty that I showed you before on our post-transplant young man. Here are the figures from this paper. So here is bronchi that are becoming obliterated. So you see these projections into the lumen that then become confluent. This is different from this scythe-like motion that we speculated in the case of Marty. It may actually have different presentations. They actually got biopsies that were not dissimilar to the ones that we showed you previously. And here is a case of an almost complete obliteration, I'm sorry, of a bronchus, probably progressing on a subsequent admission for this case. And what she ended up dying from is a diffuse process of obliteration. This is a bronchus that they tried to breach by lasering. So they lasered it. Here is what they were able to get by lasering and a dilatation, but eventually this was not successful. And as I mentioned, this child died. So what triggered this discussion was last week, when CVID was presented. I mentioned that just 2 weeks before, we bronchoscoped a 19-year-old with CVID, who we thought the driver of her progressive bronchiectasis was the multiple infections of, again, persistent infections over a lifetime, including Pseudomonas aeruginosa. And we did a bronchoscopy on her with the hope of finding unexpected bugs such as mycobacteria. And we treated her with antibiotics. And to our surprise, the cytology revealed inflammation. Cytology was predominantly neutrophil, between 80 and 90% on the two sites where we bronchoscoped, and the bacterial AFB cultures were completely negative. So a progressive bronchiectatic disease in a case with CVID and with negative bacteria. The caveat should be that the negative bacteria may have been because we gave her 24 hours of antibiotics, but it generally would not be enough to wipe out all the bacteria, particularly in a chronic situation. But what we saw in the bronchoscopy is this partial obliteration that we saw in the lingula. You can see that this is a sick broncho syndrome. The bronchoscope, the sick bronchoscope syndrome. The bronchoscope has many fibers that are broken. We clearly need to replace it, but we still could get this quality, not very good quality of photo. And here is the obliterated bronchus from another angle. Unfortunately, we're not able to get a video. And the question is that a presentation of obliterative bronchitis? Should we worry that this would follow the pattern of this lady that I just showed you and progress to more and more obliteration? And how are we going to prevent this? And another question is whether a biopsy would give us more information, whether this lady with CVID is going to an autoimmune response or an inflammatory response that is unrelated to infections. All these are questions that are very bothering. I'm not sure exactly how to proceed in this case. So when we responded to the critique by Anne Chang and Mark Everard in this letter to the editor, we agreed. First of all, we apologized that we failed to find their report. And the other thing that we did is we said, here is why we think that despite not figuring out that somebody was already published, here is what we added. We added in our publication that the obliteration is by a membrane and not just an obliteration that may not be breached. And it therefore can be breached, which we have shown in one case, but not successfully in others. Not sure what the world experience is, but if we go back to the case that I just showed you about lasering, that means that these obliterations sometimes can actually be breached. And with the case of Marty, this young man with repeated bronchoscopies and the placement of a stent, obviously this is something that can be done. We also saw the observation of natural history and course of formation of the membrane by repeat bronchoscopies, and that may give us an insight when this membrane should be broken. In other words, when you see the partial formation or what the beginning of you think is going to become an obliteration, you may want to intervene early before a full obliteration occurs, and that can be potentially done either by stenting or by lasering, preventing the full obliteration and loss of a piece of the lung. We call this paper a proposed unifying model, because what we thought is that behind this finding, there may be actually a wider message, similar to what I tried to give you when I showed you the Pohunek case, which ended up being with a bronchogenic cyst behind it. So we think, but cannot prove. This is cited from our paper. We think, but cannot prove with certainty that our observation may represent the proximate appearance of a spectrum of inflammatory processes involving the bronchial tree, which most commonly affects distal airways. Examples of such processes are lung abscess and necrotizing pneumonia. Such fluid-containing cavities of the lung presumably resolve by establishing a communication with and draining into a bronchus. So what we did not elaborate on, or we may have, I can't remember, is that when a diagnosis of abscess is made, what you see typically is that there is an air fluid level. So that air fluid level can be explained by two potential mechanisms. One is the bacterial activity produces gas. And the other one is that there is actually a communication with the bronchus into the lumen of this abscess, and that eventually the abscess completely drains into the bronchus and leaves behind this shadow cellular activity, which typically we call a pneumatocyl, that may persist for a long, long time in abscesses, but much less so in cavitatory pneumonia. Another reason to think that this is the process is that there is some literature, and I actually have some personal experience, that when you bronchoscope somebody with a lung abscess, you may actually drain the abscess by bronchoscopy. This is not usually practiced, but sometimes intentionally and sometimes unintentionally that can occur, meaning that you can drain the abscess by breaching it from the bronchial side. In necrotizing pneumonia, our unpublished observations on serial chest CT scans indicate that the liquid phase is rapidly replaced by a large air-filled cavity, presumably following drainage of liquid into communicating bronchi. We think that in these cases, the liquefying process is separated from the lung parenchyma by a discrete barrier, probably a membrane, that ruptures as the inflammation progresses, and the process ends with rapid drainage of the fluid. This is similar to what I just described for the abscess, except in the case of necrotizing pneumonia, there is no thick wall, and once the drainage occurs, usually the cavity that is formed behind it, which leads to the name of cavitating pneumonia in the English literature versus the US literature, this cavity collapses and does not usually leave a pneumatocyl. Here is an example. This is from the era where we knew little about necrotizing pneumonia and had serial CT scans to try to understand the process, because this patient was so sick that we thought that she would die on us. So here is day 4. This is CT scan with contrast, and the reason to do contrast in these cases is because sometimes you will lose the line of the pleura. What you can see in this case is that this is a collapsed or infiltrated lung with pneumonia. This obviously gray outside of the lung is the pleural effusion. Now what you can see is the pleural line, and in the lung, this part of the lung looks more than the outside grayness, which is fluid, than the consolidation of the lung itself. This process, again shown here, that the grayness here is probably liquefaction. I'm calling it liquefaction on purpose because the first description of necrotizing pneumonia in childhood was by the Jerusalem group, and they reported 4 cases of pneumococcal pneumonia with what they called liquefying lung. And so here is day 4. A CT scan 2 days later, day 6, shows the same area that has now completely drained. Here is some fluid, and this is no fluid, and this is a cavitatory pneumonia. So the rapid transition of this fluid-filled lung to 2 days later becoming cavitatory must mean that the fluid has migrated somewhere, and the only way that I can think of is that it would have drained into the bronchus. If it drains into the bronchus, then something must break for this area to drain into a bronchus. And my speculation is in this paper that this may actually be a thin membrane or a wall, that if you would have a bronchoscope that can look all the way to the wall of this abscess, you would actually be able to see it. And sometimes, as I mentioned, you can actually breach it by bronchoscopy. This is what I have to tell you. Happy to answer any question if you might have it, or any thoughts from the group.
Hi, Andrew. This is Tassos.
Hi.
Can you hear? Okay. Very nice presentation. I do have a sort of a question and comment. We did have, as a matter of fact, a case that struggled with. It was a patient with sickle cell disease who underwent doing fine, and then she had a very dramatic deterioration. To make the long story short, we did
Tassos,
bronchoscopy.
can I interrupt you quickly?
Yeah.
I have a picture of that bronchoscope. Andrew, if you let me share my screen,
Sure.
I can show you.
Let me just I am not, for some reason, I'm not getting there.
I just copied a picture of your bronch, Tassos, so with the membrane for that patient, so I can show it while you're talking.
So I think, so I stopped sharing, so I think you should be able to now.
Can you see it now?
Oh, wow. Yeah.
Okay.
So this girl had extensive membranes that were going all the way almost to the main stem bronchi. And they were very thin membranes, very translucent. And the interesting thing is that we did break them actually, and we tried many different ways. We tried with brush, we tried with the bronchoscope itself. We put anything that we could instill inside, and they were breaking pretty easily. However, they were forming right back. And she had several bronchoscopies, and they would form and they would advance, upstream, proximally. And eventually she died actually, and she literally suffocated. And we think that she had these lesions all over the place, but these were not abscesses. There were no really secretions underneath. These were just membranes occluding the airways, which is a little different. They look much more and they make much more sense with what you describe in one of your slides, the one that you have the progression of the obliteration, because this is how they seem. We could see different stages, that it starts forming from the wall and it's moving. It is like the shutter of a camera. this is how it progresses, and eventually it closes completely, in the middle. The only organism that we had for this girl was adenovirus that had happened actually long before she presented with a rapid deterioration. So we don't really have a mechanism. Now, I have seen in certain bronchoscopies obliteration of what seemed to be a bronchus at some point, and the question was, and these were incidental findings, and I did not really know whether that was obliteration or something that did not develop in the first place. When the child, was, before actually he was even born. So I don't have any answers, but it seems to be a variation on the theme and did not respond to anything. I mean, yes, you can break them, but new ones are forming. Before you have time to withdraw pretty much, you have obliteration of other areas.
Fascinating, absolutely fascinating. What can I say? I mean, the point that we made in our paper is that we are calling it membranous obliterative bronchitis as a descriptive term that has nothing to do with etiology, because we don't know etiology and it may be variable. And the reason that we went to the next publication is to make sure that people